Hello, today we'll continue with our series of lectures on behavioral science. Last time we talked about sexuality, so we talked about, remember that sexuality is not just about having sex, but it's also about the sexual differences between the genders. So we cover the first topics, and now today we're going to cover the remaining topics of the issue of sexuality. We'll concentrate today on uh, sexual dysfunctions as they're categorized in the DSM-5, and also some paraphilias, which is always a fun topic, at least in my view. Remember, as usual, all of these topics will appear in the USMLE Step 1. So at the end of this lecture, we'll do some review questions to cover all the topics that we already covered here. So let's begin by considering exactly what sexual dysfunction is. Well, sexual dysfunction is some problem when having sex. There are many types, and the DSM-5 gives us some criteria. They are, although they are all included in the DSM-5, they're not all necessarily, let's say, they're not necessarily psychogenic. That is to say, they're not all necessarily of a mental origin. There can be some other physiological problems that cause sexual dysfunction, but ultimately they cause some mental distress, so that's why they are included in the DSM-5. We can say that there are two types of sexual dysfunction. First of all, there is primary sexual dysfunction, and those are sexual dysfunctions or problems with having sex that have always been present. And there is, that is to say, I mean, it's always been a problem for the patient. Whereas secondary sexual dysfunction, it is when the sexual function has been normal, but eventually there appears some dysfunction. Secondary sexual dysfunction is much more common than primary sexual dysfunction in terms of epidemiology. So let's begin with the first one, and it's probably one of the most common sexual dysfunctions out there. It is categorized by the DSM-5. It is delayed ejaculation, and this is basically when people have sex, and males, of course, they're the only ones who ejaculate. Males have some problems reaching orgasm, so their ejaculation is delayed. So the DSM-5 criteria gives us some guidelines about how to diagnose this. So first of all, in order to diagnose this, first you need to have either of these symptoms in 75 to 100% of sexual activity. So first of all, there is a marked delay in ejaculation. Usually, we cover this in the previous lecture. Remember that during penetration, that's the Plato stage of the sexual cycle. Usually, penetration it varies, of course, but you know the expected time is around between 5 and 7 minutes. Now, if after 5 or 7 minutes of the Plato stage or penetration, the male doesn't get the ejaculation, then that may be considered marked delay in ejaculation. Another symptom is infrequency or absence of ejaculation. So it's either marked delay in ejaculation or infrequency or absence of ejaculation. That is having sex without actually reaching an orgasm and having ejaculation. It's no fun, I suppose, and that's why it is considered a disorder. Now, these symptoms have to last for at least 6 months, so you shouldn't rush to judgment and diagnosis. And of course, the symptoms cause distress. Now, it's hard for me to imagine how someone could have delayed ejaculation and not get in distress, but there might be a few people who have delayed ejaculation, but it's not really a problem for them. If it's not a problem for them, then it shouldn't be considered a disorder. Remember that a very important criterion when it comes to diagnosis in almost every mental disorder, it is distress, and that is one of the most important differences between normal and pathological behavior. So, what causes this and what can be done about it? Well, there can be many causes in delayed ejaculation. There's infections. So, as I was telling you, many of these sexual dysfunctions, some of them may have psychogenic causes, but not all of them. And there is a tendency, not so much in the case of delayed ejaculation, but in the case of erectile dysfunction, and also in the case of premature ejaculation, there is a tendency in the media to believe that all of this is psychogenic. And if you have some impotence problems, if you have an erectile disorder problem, then it's because either you are depressed or you don't believe in yourself or or you have a lot of anxiety. And that may be the case, but that's not necessarily the case all the time or for all patients. So unfortunately, the media presents this as if sexual dysfunction problems are all psychogenic, but that's not necessarily the case. So, in the case of delayed ejaculation, well, there are some causes that are not psychogenic. Infections. If you had prostate surgery, you may have a delayed ejaculation. And then, of course, there are the psychogenic causes, depression, anxiety about performance. This is one of the most common psychogenic causes of almost every sexual dysfunction, or anxiety about performance, especially among younger people. Poor body image, differences of reality and fantasy. This is another big one, and this is why there are so many critics of pornography. The jury's still out about whether or not pornography is harmful. It certainly may become an addiction, but it has been vilified by a lot of people. And there's a lot of media hype about how bad pornography is, and psychiatrists and psychologists are not so sure about the extent of how bad as pornography is. And actually, pornography in some cases may actually be even healthy to stimulate arousal in couples and so on. Now, one problem of pornography, and this is accepted by pretty much all mental health practitioners, is that there may be a huge mismatch between reality and fantasy. And it's okay to have fantasies, and it's okay to watch things that are not real, but as long as your mind gets to know the difference. Now, if you watch a lot of pornography and you see a lot of fantasy on the TV regarding how sexual relations go, well, when you come to the real deal and you realize that maybe your sexual life is not doesn't really resemble what you see on TV, then that may cause some sexual dysfunction problems. And also another cause of delayed ejaculation may also be high blood pressure medications. So what's the treatment for this? Well, the FDA has not approved any drugs yet for the treatment of this. So so far, mostly the treatment here is mostly psychotherapy, and it's usually, I mean, if this comes as a result of a depression or anxiety, then when we get to those disorders, we'll see that the first line treatment for those disorder is cognitive behavioral psychotherapy. And there is also another possible treatment, what's called the sensate focus exercise. And this is recommended by a lot of sex therapists. And this is stimulating a person's senses during sexual activity, that is to say, caressing each other and so on, in order to reduce the pressure one experiences when trying to achieve an erection or orgasm. So, this is trying to become a little bit more relaxed while having sex, and that may eventually help you achieve orgasm. Let's talk about another very common sexual dysfunction disorder, erectile disorder. Uh, let's consider what the DSM-5 criteria is. First of all, you must have one of these symptoms, again, for 75 or 100% of sexual activity. So if you have if you have managed to have erection, but that erection but for 70, but nevertheless, even if you have erections, that's not a guarantee, and that you may not have erectile disorder, because you may have had one erection. But if during 75% or more of the time of sexual activity you don't manage to get an erection, then you may have reason to believe that either you or the patient you're trying to diagnose does have erectile disorder. So if one of these two symptoms must be for 75 or 100% of sexual activity. First of all, difficulty obtaining an erection, and also difficulty maintaining an erection. So it's not just getting there, but it's also staying there, what's important here. The symptoms must be there for more than 6 months, and of course, well, the symptoms must cause distress. Again, I find it a little bit difficult to believe that some people may try to have sex and not get an erection and that they're okay with it. But nevertheless, the DSM-5 makes the warning that if someone doesn't really feel distress about this, then they shouldn't be diagnosed with this disorder. Causes, well, heart disease is very has a strong link to erectile disorder because, well, remember that the penis becomes erect by receiving a lot of blood flow. So if there are heart problems, then that may ultimately influence how erections go. High cholesterol, high blood pressure, diabetes, alcoholism. We'll get to alcohol later on, but for the time being, let's it suffices to know that maybe in the short term, alcohol may arouse sexual interest, but in the long term, it significantly impairs sexual function. So, I mean, there is the myth that when you drink, you see other women more beautiful, and you know that you want to have sex, and you want to have sex with all of them. But unfortunately, alcohol has a strong correlation with erectile dysfunction. So, you know, having drink before sex is not such a great idea. Of course, we're talking here about alcohol use disorder, which is, you know, long-term use. But still, there is a correlation between alcohol use and erectile dysfunction. And also psychogenic causes also play a role here. So depression, anxiety, and stress. What's the treatment for erectile dysfunction? Well, I'm sure you've probably seen these all over the media. Sildenafil, which is the generic name for Viagra, which is the brand name. Unfortunately, sometimes Viagra has been abused by some people, especially youngsters, who take it, who self-medicate in order to boost even more sexual erectile dysfunction, to enhance more their sexual performance. But that may have some very dangerous side effects. You may have permanent erections, which are, you know, they can be quite dangerous. So what does sildenafil do? What does Viagra do? Well, it enhances the effect of nitric oxide and thus relaxes the muscles in the penis and allows for more blood flow. So this is how erectile dysfunction is treated here by this medicine. If the problem is psychogenic due to depression, anxiety, or stress, then psychotherapy is a line of treatment, an important line of treatment. And a more extreme or a more for more severe cases, there can also be penis pumps and implants. And of course, here you see what a penis implant looks like, how it works, but they are surgically implanted. So there may be some patients that may be contraindicated for this. So it may be a line of treatment, but you know, this decision must not be taken lightly. Okay, so far we've talked about gentlemen. Let's talk about the ladies. In Latin America, there's a saying always "ladies first," but here we're not following. So, well, actually, we are talking first about men because it's more frequent in terms of epidemiology. The first disorders that I talked about. Women do not suffer as much from this disorder as men. But of course, they may also suffer. That doesn't mean that they don't suffer any. They also have some sexual dysfunction disorder. So let's take a look at a few of them. First of all, there's female orgasmic disorder, and as we talked about in the previous slide, remember that the refractory period for men is different than the refractory period for women. So after a man has an orgasm, his sexual arousal comes all the way down, and he's not ready for another orgasm for at least 15 or 20 minutes in healthy people. Whereas for women, it's different. I mean, once they reach if they reach the orgasm, they may be ready for even more orgasms. And of course, if the man reaches the orgasm and his sexual arousal comes down, then unless she uses masturbation, the woman will not reach orgasm after the man has reached orgasm. So that's why some sexologists recommend that if a man reaches orgasm but the woman doesn't reach orgasm, that masturbation, even in front of the man, may be recommended. Um, so female orgasmic disorder is, well, basically when women are not able to reach orgasm, or the orgasm is not very intense. So let's take a look at what the DSM-5 has to say about this. Well, in order to diagnose this, first of all, one of these symptoms has to be present for 75 to 100% of the time that you have a sexual activity. And it's either one of these symptoms. First of all, delay or absence of orgasm, or number two, reduced intensity in orgasm. And as in the other sexual dysfunction disorders, um, the symptoms must be present for 6 months or more, and this must cause distress. Again, if a woman doesn't reach orgasm but she's okay with that, then this shouldn't be diagnosed. And this can cause some disruption in married life and in couples. So it's important to take care of this, and it's important for men to understand the importance that women have orgasms. I mean, as maybe in previous eras, it wasn't expected that women should have orgasms. That they were just there to give men pleasure and so on. But things have changed, and now we're beginning to understand about the importance, for not only for mental health of the women, but also for the importance of marriage stability in order to have a meaningful sex life. And in order to have a meaningful sex life, well, women need to have orgasms as well. So what are the causes and treatment of this? Well, there may be a history of abuse and rape, so this is a psychogenic cause. There may be boredom in sexual activity. This is very important. I mean, it's important for couples to try new experiences. If they're both achieving orgasm, then there is no need to experience new things because everything is going well. But if either the man or the woman become bored because it's always the same, well, they should try new things. So boredom in sexual activity can be a cause of a female orgasmic disorder, and this is something that couples should address. Anxiety, stress, and depression, all of these influence the absence of orgasms in women. But again, not all causes are psychogenic. There can also be a hormonal disorder, so maybe some hormonal imbalance doesn't allow women to reach orgasm. Vaginal dryness, this is more related to older age, but younger women can also suffer from this, and it may ultimately lead to a lack of orgasms. And vaginal dryness is, although it's a physiological symptom, it may also have some psychogenic causes, although again, not necessarily, but boredom in sexual activity may cause vaginal dryness, which at the same time causes a lack or an absence of orgasm. Another cause, pelvic pain. So pain in the pelvis. If the woman is suffering that pain, then that may prevent her from getting an orgasm. What's the treatment here? Well, remember that this may have an hormonal cause. So estrogen may be prescribed for this type of disorder. But then again, if the disorder, if you find out or you diagnose or you have reason to believe that the origin of disorder is psychogenic, then the line of treatment here is psychotherapy. And in as much as this probably has to do with anxiety, stress, or depression, then the line of treatment here for psychotherapy should be a cognitive behavioral therapy. And as in the other sexual disorders that we talked about previously, the sensate focus exercises, that is to say, stimulating the senses with caresses or other forms of touching each other and so on, those can really be helpful when trying to reach orgasm. Okay, let's take a look now at female sexual interest or arousal disorder. Let's consider what the DSM-5 criteria has to say about this. Well, in order to be diagnosed with this disorder, first of all, there must be a lack of sexual interest with 3 or more of these symptoms. First of all, absent interest in sex. So, the person just doesn't really care about having sex. Absent fantasies or erotic thoughts. Fantasies are important when it comes to sex. And I know that in previous eras, especially during the Victorian times, for instance, fantasies were heavily repressed. And today we may be overexposed to fantasies, and this may cause problems between a mismatch between fantasy and reality, as I talked previously. But we should strike a balance. I mean, too much fantasy may cause the problems that I already addressed. But the lack of fantasies may also cause problems in the sense that you may not be sufficiently interested in sex, and that may cause some distress. So fantasies are important, and just because they may cause some problems if you're exposed to too much fantasies due to pornography and so on, that doesn't mean that you shouldn't have fantasies. Sexual fantasies have a role to play. Okay, so let's continue with the criteria. Number 3, no initiation of sexual activity. Number 4, absence of response to sexual stimuli. Number 5, absence of genital sensations during sex. So if you have 3 or more of these, then you meet criterion A for a female sexual interest arousal disorder. The symptoms must be present for more than 6 months, and very important here, the symptoms must cause distress. Now, why do I want to make special emphasis on criterion C for female sexual interest arousal disorder? Because let's take a nun, for instance, a Catholic nun who's not supposed to have sex, and I suppose that some nuns don't really take this seriously and they may have sex, but some other nuns really do take it seriously. So let's suppose there is a nun who really doesn't have any interest in sex. She sees some very handsome guy and she's not sexually aroused. She doesn't take any initiation in sexual activity. She doesn't have any fantasies or erotic thoughts or anything like that. So she's pretty much asexual. Now, should she be diagnosed with female sexual interest arousal disorder? Well, no, because this is not causing distress on her. I mean, she has chosen that way of life, and if the nun is happy with that, then she shouldn't be diagnosed with this. I mean, remember, the people that are most likely the patients that are diagnosed with this are patients who are married or who have boyfriends and who may have sex, but they are not really interested in that. So they may just have sex to please the husband and so on, but they're not really interested in this. They don't find pleasure in this. They're not aroused, and of course that does cause distress, either to themselves or to someone else. So this is why I'm saying that criterion C is quite important in this regard. Okay, let's look at another disorder for women. There is a genital pelvic pain or penetration disorder. This used to be called vaginismus, which were painful spasms, and dyspareunia, which was pain during sex. Now the DSM-5 and the DSM-4, they used to be considered 2 separate disorders. DSM-5, now they put them together. And the criteria is, well, you should have difficulties with 1 or more of these in order to be diagnosed. And first of all, vaginal penetration. So if during sex you have difficulties in getting the penis inside the vagina because it may hurt or for other reason, then that's one of the symptoms for criterion 8. Number 2, pelvic or vaginal pain during intercourse. So if your vagina hurts or your pelvis hurts during the intercourse, that may be another symptom. And also, number 3, fear and anxiety in anticipation of pain. Number 4, tightening of the pelvic muscle during penetration. So all of this causes painful spasms or pain during sex. If you have 2 or more of these symptoms, then you have met criterion A. Criterion B is that these symptoms must last for more than 6 months, as in almost every other sexual dysfunction disorder we've been talking about, and the symptoms must cause distress. It's hard for me to believe that a woman who has sex and it really hurts, that doesn't cause distress. But again, if the patient doesn't seem to have distress, then it's okay. Now, remember something important here that we haven't mentioned. I mean, maybe the patient expressly says that it doesn't cause distress, but you as psychiatrists, you have to scratch a little bit under the surface. I mean, it's not enough for the doctor to just take the patient's word for it. The patients may say one thing, but they may really feel something else. So remember that in the doctor-patient relationships, maybe one of the techniques, maybe in the doctor in interviewing, maybe a confrontation. So if the doctor sees something that is very incongruent, and the patient may say, "Oh, I feel great," but then you see other signs that they're really distressed, then maybe they should be confronted in order to address this. Now, there is the media image and the myth that males are more interested in sex than females. And maybe for evolutionary reasons, there may be some reality behind that. But this has been exaggerated in the media. So females have as much interest or not necessarily as much, but females have an interest in sex very much as men have interest in sex. Now, having said that, in the same manner that there may be some disorders for females, for women, who are not all that interested in sex, there are also some disorders for men who are not interested in sex. And this is the male hypoactive sexual desire disorder. Remember that hyper is the Greek prefix that means too much, and hypo is the Greek prefix that means not enough. So here is the male hypoactive sexual desire disorder. Well, it's the disorder for males when they don't have enough sexual desire. So the DSM-5 criteria is, well, first of all, a deficient or absent interest in sexual thoughts, fantasies, and desires. So, males who are not interested in sex. B, symptoms for 6 months or more. And C, all these symptoms must cause distress. Again, I want to emphasize C here, because very much as in women, there may be some nuns who are not interested in sex, but they're not distressed, so they shouldn't be diagnosed with this. The same goes here for men. I mean, if you take the Pope, does the Pope suffer from male hypoactive sexual desire disorder? Well, I wouldn't say so, because even if he has no interest in sex, and even if he has no thoughts or fantasies or desires, and sure, he has been having this for more than 6 months, and that doesn't mean that he has a disorder, because he's not suffering from this. The symptoms are not causing distress. It would be very different if he had a lover, and the lover was asking him to have sex, and okay, well, he's having sex, but just to meet the lover's demands. But he's not really enjoying it because he's not interested in having sex, but he's having sex nevertheless, and that causes distress. Well, that's different, because in that case, those the hypoactive sexual desire symptoms would cause distress. So let's keep all that in mind, okay? The criterion C here is very important. So what are the causes of and treatment for male hypoactive sexual desire disorder? Well, there may be hormone deficiencies. Remember that sexual activity has a lot of relation with the endocrine system. There may also be psychogenic causes, so depression, anxiety, marital distress, and poor body image. When we get to other disorders regarding body image, body dysmorphia, and so on, we'll take a closer look at what they are. But if you don't feel good with your own body, then you may not be all that aroused in having sex. There's some reason why in hotels that are designed for sexual activity, they put a lot of mirrors there, because one way to get you aroused is by looking at yourself. Now, if you're not happy with your own body image, then you may not be all that, you may not have a lot of sexual interest. The treatment here, well, psychotherapy, if the causes are psychogenic, if they're not necessarily hormonal. And that's the first line of treatment. And if it's a little bit more severe, in the case of depression, then maybe some antidepressant medication may be needed. Okay, let's consider another sexual dysfunction disorder. This is one of the most common, perhaps probably the most common of all, along with erectile dysfunction. This is a premature or early ejaculation. And this is more common amongst youngsters than among the elderly. The DSM-5 criteria is, first of all, a pattern of ejaculation 1 minute after penetration. So in the case of delayed ejaculation, it's taking too long in order to ejaculate, or maybe not even ejaculating at all. Here in the case of early ejaculation, is ejaculating too fast, too quickly. So a pattern of ejaculation 1 minute after penetration, and of course before the individual wishes it. The second criterion is that the symptom must be present for 6 months in 75 or 100% of sexual activity, and the symptom must cause distress. So as I was saying, this is more common in youngsters because older men eventually come to learn how to delay orgasm. And there are various techniques, even psychological techniques. I mean, this is not all that proven, but it has been argued by some sex therapists that when you're coming close to orgasm, if you think about something else, that distraction may eventually delay orgasm a little bit. And you may ask, well, what's the point of delaying orgasm? Why don't you just have the orgasm and that's it? Well, remember here that sexual activity you want also your partner to be aroused, and it takes them a little bit longer for women to have orgasm. And once you have orgasm, remember, your refractory period may be longer, and your sexual arousal may come down, but the women have a much shorter refractory period, so they're ready for another orgasm. So in order to please the partner, it's important to, if you think that the penetration has been too short, it's important to try to delay orgasm. So some of the causes of premature ejaculation, well, there may be anxiety, guilt, and depression. In some cases, hormonal problems, and here we come again with alcohol use. There are some treatments for this. First of all, relaxation techniques, especially if you think that the cause may be psychogenic, related to anxiety. And it's usually related to anxiety. I mean, especially anxiety about performance. Distraction methods, as I was telling you. Also, it's important partner communication. I mean, if you're having sex with a woman and the woman is telling you, wait for me, don't go so fast, give me a chance, come on. Well, partner communication is important. If you listen to that, then you may be able, or at least you may be aware of the need to delay a little bit orgasm, and you may attempt it and eventually succeed in delaying orgasm a little bit. And there is also the squeeze technique. And the squeeze technique is that the partner, just prior to orgasm, she may squeeze the penis, and this is quite successful in delaying orgasm. So the squeeze technique is also recommended by sex therapists when it comes to problems with premature ejaculation. And if the causes are definitely psychogenic, then psychotherapy is an important line of treatment. And usually, in as much as this is most likely related to anxiety or guilt and depression, then the line of treatment here should be cognitive behavioral therapy. Now, in the DSM-5, remember that the DSM-5 they discussed the new criteria back in 2013, and the way this usually works is that the psychiatrists, American psychiatrists, get together and they discuss the criteria for the disorders that were already included in DSM-4. Maybe they take out some, maybe they propose to incorporate new disorders. And one of the disorders that was proposed for DSM-5, it was intended to be included in DSM-5, but it was eventually left out, was the hypersexuality disorder. Now, this is supposed to be a disorder when people have too much sex, and this causes distress. So it was pretty much like sex addiction. Now, it wasn't really included because the neurological model for this was different from addiction to, let's say, cocaine or tobacco or alcohol. So it was not included. And of course, and there's the question of, well, when exactly is sex excessive? I mean, if you have sex, let's say 5 times a day with your wife, why should that be a problem? I mean, as long as it's as both of you are enjoying, what's the big deal? And even if even if we come to agree that sometimes sex may be excessive, there is really no. It's difficult to establish a defining line between excess and normality. I mean, how many times a day? Let's say 3 times a day, 4 times a day. How many times a day is it okay to masturbate, and so on. So, you know, because of the thin line that we have here when deciding what's normal and what's pathological, that was another reason not to include hypersexuality disorder in the DSM-5. Now, make no mistake about it, there are some people that may be distressed by too much sex. And here I show you 2 movies that have been recently out that address this problem. The first one from Lars von Trier, who's a Scandinavian director, and some of his movies are really disturbing. I watched this one, Nymphomaniac, and this is especially disturbing. It's about a girl who just has a lot of sex, but she eventually comes to have a lot of distress because at first she gets aroused, but then at the end she just has sex and she doesn't even understand why. It becomes pretty much like an addiction to her, and she suffers a lot. So this is one good portrayal, and the other one in movies is Shame, and I don't know if you've seen it. It's quite a famous movie over the last few years because it also tells a similar story, but this time from the perspective of a man who's not able to hold stable relationships, and he suffers from this because he has a, I wouldn't call it an addiction because again the neurological model here might be different, but he certainly has something close to that. So that's another movie that's been recently out in the media and that portrays this. Now, remember when I was talking about pornography? The jury's still out about what psychiatrists think about pornography. Because related to this idea of hypersexuality, there's also the issue of pornography addiction. So psychiatrists disagree over whether or not there is such a thing as pornography addiction. I mean, the neurological model for when watching pornography is quite different from taking cocaine. So, you know, there's still discussion about this. Just because you enjoy a great deal of something, that doesn't necessarily mean that you're addicted to that in the same sense as being addicted to cocaine. There's some people who believe that maybe too much masturbation may be a problem, but psychiatrists are not so sure about that either. I mean, at most, it might be a derivation of obsessive compulsive disorder or some impulse control disorder that just, you know, people cannot control masturbating, so they do it publicly and so on. Or histrionic personality disorder, you know, when they want to have their attention on them. But in this case, it wouldn't be really a hypersexual disorder, but more a disorder that's more related to, you know, histrionic personality or to impulse control. So none of this. That's why pornography addiction and hypersexuality and so on, they were not included in the DSM-5. Okay, let's talk now about another very interesting topic of sexual disorders or conditions that are included in the DSM-5, and they're the paraphilias. And now, paraphilias are sexual feelings or behaviors that may involve sexual partners that are not human, that maybe are not consenting, or that involve suffering by one or both partners. Now, the inclusion of paraphilias in the DSM-5 has also been controversial because, again, there is no precise border between unusual sexual interests and paraphilias. So let's say that I really like leather and I'm aroused by latex and leather and the use of handcuffs and so on. And I like to play these games with my wife, and I like my wife to be dressed in leather, and my wife also likes to be dressed in leather, and we play these games where she's a dominatrix and I go along with that, and she cuffs me, she puts handcuffs on the bed, and we have sex, and well, we really enjoy it, and we're all happy, but we have this fixation on leather or latex or handcuffs or whatever. Now, why should that be pathological? I mean, there is no precise line between unusual sexual interests, and this to a certain extent is unusual, although media images have done their share of propagating this. But anyway, there is no precise border between unusual sexual interest and paraphilia. So this is why there's still some discussion about whether or not some paraphilias should be included in the DSM-5. And what is exactly a paraphilia? I mean, where does a paraphilia begin and where does an unusual sexual interest end? So having said that, well, let's consider what the DSM-5 has to say about the paraphilias. The DSM-5 criteria is, first of all, an intense sexual arousal from specific paraphilia for more than 6 months. Second of all, and this is the important part, paraphilia causes distress or is acted upon a non-consenting person. So, I mean, if I'm really if I'm really aroused by latex and leather and boots and whips and all of that, and I ask my wife to participate in that, but my wife is not much into that, but I force her to do it, or I manipulate her, or I blackmail her into playing this, and well, she eventually does it, but very much against her will, then that may be a case of paraphilia, because it's causing distress. Not necessarily on the person who has the paraphilia, but on the partner. And if that causes distress either to the person himself or to the partner, then that meets criterion B for paraphilia in the DSM-5. So there are many types of paraphilias, and let's consider the ones included in the DSM-5, although there may be some others that are not included in the DSM-5 but are still out there. But let's consider the ones included in the DSM-5. There's first of all voyeurism, and this is being aroused by watching other people having sex. So this is the peeping Tom. And well, this may become a problem if you become sexually aroused by watching other people having sex. Well, it may come a time when you just are not able to have sex because that's the only way you're aroused. And if you feel distressed because of that, because you do want to have a partner but you're not able to have it because the only way for you to get sexually aroused is by being a peeping Tom, then that's a problem, and that meets the criterion for the according to the DSM-5 criterion. So that's voyeurism. There's a related paraphilia that's not included in the DSM-5, but that's becoming ever more frequent, and I have some friends, I've met some people that have suffered this, and it's called cuckoldism. And this is the idea not just of watching other people have sex, but watching your own sexual partner have sex with another person, and you become stimulated by this. This is usually exploited in pornography, but it doesn't only happen in pornography. I mean, in real life, it's a real paraphilia. Exhibitionism, it's another paraphilia included in the DSM-5. Well, this is sexual arousal by having sex while exhibiting yourself to other people. So, there are some people who really get aroused by the idea of other people watching them. And exhibitionism may be related to histrionic personality, and if it's severe enough, it may be histrionic personality disorder. So there are comorbid conditions, exhibitionist paraphilias, and histrionic personality disorders. Frotteurism, this is a rather interesting one. Frotteurism is being aroused by rubbing your genitals against another unsuspecting person, either in the bus or in the street or somewhere else. So if you're in a bus and it's crowded and you have this paraphilia, so you get close to a girl's butt and you get right next to her in the bus while both of you are standing, and you begin to rub your genitals against the girl's genitals or against her butt and so on. If you get sexual pleasure from that and arousal, then that's paraphilia, and it's called frotteurism. Masochism, I'm sure you know what this is. This is the paraphilia where you get sexually aroused by suffering yourself, by receiving pain. Um, Sadism is being sexually aroused by providing pain to other people. So this is why some people say that masochists and sadists get along very well, because some of them want to be punished and the other ones want to punish. And again, I want to stress here that it's only considered a disorder if it causes distress. So if a masochist finds a sadist and they're both happy with it, then that wouldn't be really considered a disorder, because I mean the masochist wants to suffer and the sadist wants the other person to suffer, and if that doesn't cause distress and they are both consent to that, then there shouldn't be no problem. Now, consent is a tricky word, and there is a lot of philosophical discussion about exactly what consent is. But I'm sure you're able to recognize. I mean, just because someone signs a paper, that's not necessarily consent, and there must be some other conditions too. I mean, the person must be in a stable peace of mind and so on. But if you know how to recognize consent, then if there is consent in these behaviors, then they shouldn't be considered disorders. There is pedophilia. This is a more serious matter, and that's being sexually aroused by having sex with children. There is some philosophical and juridical discussion about whether or not someone that is aroused by children's images of having sex is really a disorder, or, well, it is a disorder, but it's not necessarily a crime. So, for instance, let's say that you feel aroused by child pornography, but it's not really child pornography, but just cartoons of children having sex. Now, that's definitely pedophilia. I mean, because it is a disorder. But here, the more philosophical question is, who's actually suffering from this? I mean, because no children are being abused, because unlike the case of child pornography, if the person is consuming pornography of cartoons that depict children having sex, then there doesn't really seem to be a victim here. But nevertheless, I think psychiatry would consider that a pedophilia. There is a fetishism, which is sexual arousal with objects. I guess, being aroused by leather and latex and handcuffs, the things that I was talking about previously, that's fetishism. And transvestism. And transvestism is about being sexually aroused while wearing clothes of the opposite sex. Now, this is different from gender dysphoria. If you remember from a previous lecture, we included a question from the USMLE that addressed this topic. Now, just because someone enjoys having sex, if they're a man, if they enjoy having sex, being dressed as a woman, that doesn't qualify as a criterion for to diagnose gender dysphoria. It would be at most a transvestism. And transvestism, well, it's not necessarily a disorder if it doesn't cause distress to the person. Okay, time is flying here, so let's speed it up a little bit. Let's talk about heart disease and sexuality. Well, men and women with a myocardial infarction may have decreased libido due to the side effects of medication. So what can you do about it? Well, if the patient tolerates 110 to 130 heartbeats per minute, then sexual activity is okay. If not, then there might be a danger. So this is pretty much the same as going up some stairs. If the patient can handle going up some stairs for, let's say, 1 or 2 stories, then it's okay. He may have sex or she may have sex. For patients that have heart disease or that are under infarction medication, uh, the recommended thing here is to have easy sexual positions, and that's, for instance, being in the inferior position because they're more easy, they're easier from a physical point of view. So that's a recommendation for those patients. Patients with diabetes may also have some problems regarding sexuality. 25 to 50% of diabetics suffer erectile dysfunction, although they may have less problems with orgasms. So in the case of people with diabetes, it's more erectile dysfunction than orgasms when it comes to problems. This is because there are damages to the blood vessels and nerve tissue, and that can cause erectile dysfunction. Viagra is effective in treating diabetes-related erectile dysfunction, and penile implants may be an alternative, although in the case of diabetes, you have to be especially careful here because there may be problems with wound healing. Remember that diabetic patients have problems with getting scars and wound healing, and also susceptibility to infection. So if you're going to consider penile implants, you have to be careful here because the procedure is surgical. Uh, Injuries in the spinal cord may also influence sexual dysfunctions. So spinal cord injuries are first of all related to orgasmic dysfunction. They're related to retrograde ejaculation. They may have some influence in reduced testosterone. And in the case of men, there may be decreased fertility. In the case of women, spinal cord injuries may also cause some vaginal lubrication problems. Now, you may remember when we talked about developmental psychology, we covered some of the changes that people go through as they age. And aging has also some influence on sexual functions. So some of the physical changes as a result of aging regarding sex is, well, first of all, in the case of men, slower erections, a diminished intensity of ejaculation, so the sperm count may decrease a little bit, a longer refractory period, so between orgasm and orgasm, it may take longer, and a need for more direct stimulation. In the case of women, the process of aging may eventually influence vaginal thinning, a shortening of vaginal length, and an increase of vaginal dryness. In the case of women, an alternative for this may be hormonal. So estrogen replacement therapy may be recommended for these symptoms as women age. Now, let me be very clear about this. This doesn't mean that all people are not able to have sex and that they are condemned not to have sex. No, sexual interest does not usually change significantly with increasing age. So now it's important for aging people in order to have sex, well, to keep good health. So continued sexual activity is associated with good health. And here, the principle of using it or losing it applies. So there may be an atrophy of sexual organs. So this is where it is recommended for aging couples to still try to have sexual activity, because a decrease of sexual activity may eventually lead to atrophy of organs. Or, if they don't use it, they lose them. So this is why sexual activity should really be prolonged into elderly age. Let's talk about substance abuse and sexuality. Let's first of all talk about alcohol and marijuana. Well, when people who consume alcohol and marijuana, there may be a short-term increase of sexuality because psychologically there is a decrease in inhibition. So maybe you like a girl, but you don't really dare telling her that you want to have sex with her. Well, if you smoke a joint or you have a few drinks, then you may become less inhibited in order to tell that girl that you really want to take her to bed. However, there may be problems in sexual performance. So, maybe marijuana and alcohol may help you getting a girl to bed, but once you're in bed, alcohol and marijuana may actually impair your performance. And also, it may be problematic in the long term when it comes to sexual function, because the long-term alcohol use may cause dysfunction, causing higher doses of estrogen and causing sexual dysfunction. And also, the chronic use of marijuana reduces the testosterone level, and as you know, testosterone is related to sexual activity. So again, sexuality may be a problem. I'm sorry, the consumption of marijuana or cannabis may be a problem here. Let's talk about amphetamines and cocaine. Now, amphetamines and cocaine, they stimulate the dopamine systems, and the dopamine systems in the brain are related to reward, and they increase sexuality. So unlike alcohol and marijuana, amphetamines and cocaine, in as much as they're stimulants, well, and they may certainly increase your sexual performance, but of course, I mean, the side effects are tremendously risky. And when we get to substance abuse disorders, we'll cover them in greater detail. It's important to know that cocaine may cause priapism, which is a constant erection. When we talked about Viagra, we mentioned that this may be a problem in people who take Viagra without the proper guidance of the doctors. And the same here goes for cocaine. So cocaine may cause constant erection. In the case of heroin, because it's not really a stimulant, it's a derivation of opioid. Heroin causes decreased libido, retarded ejaculation, and a failure to ejaculate. Okay, and for our last point, let's talk about HIV and sexuality. Here you have a map of HIV prevalence. You can see that the darker shade countries are in sub-Saharan Africa, where this is really a big tragedy. The lighter shade is Western Europe, Asia, and Latin America. So it's important to know this data, well, for epidemiological reasons. HIV, of course, is related to sexuality, because sexual contact is a transmission, is a way that the HIV virus may be transmitted. So let's take a look at some HIV transmission risks when it comes to sexuality. In anal intercourse, there is a 1 in 10 probability of being infected with the virus. In vaginal intercourse with an infected man, there is a 1 in 200 chance. And in vaginal intercourse with an infected woman, there is a 1 in 700 chance. Now, direct contact with the blood of an HIV infected person, that's also another way of transmitting HIV. There is a transfusion. When there is transfusion of blood, there is a chance of 95 in 100, so there's a 95% chance that the person will become infected if the donor is himself infected. Needle sharing, this is a problem especially for heroin users, and when we get to substance abuse disorders, we'll consider again the risk of HIV. Well, in the case of needle sharing, the risk is 1 in 150. There is also mother to fetus transmission. If the mother is HIV positive, she may pass the virus to the fetus. So the mother to fetus probability of passing the HIV virus is 1 in 4, although there are ways of handling this. So this is why pseudovutin is a line of treatment for women who have HIV and are pregnant, in order to avoid passing that to the fetus. So if the mother does take a pseudovutin, well, the chance decreases, so it becomes slightly less than 1 in 10. Women are likely to develop AIDS quicker than men. So that's something that should also be taken into account. Okay, so that should wrap up our lecture. Let's take a couple of USMLE questions and consider the options. So let's take a look at the first one. A 30-year-old male patient who is HIV positive asks the doctor what type of sexual behavior poses the most risk for transmitting HIV to his partner. So the doctor's best response is A, anal intercourse, B, fellatio. Fellatio is a woman having having oral sex, practicing oral sex on a man. Cunnilingus, and this is a man practicing oral sex to a woman, or vaginal intercourse. Well, the best response here is A, anal intercourse. That's when there's the greatest risk of sexually transmitting HIV to a partner. And let's consider one more question. A 25-year-old man masturbates by rubbing against women in crowded buses. This man is exhibiting which of the following paraphilias? A, fetishism, B, exhibitionism, C, frotteurism, D, voyeurism, or E, sexual masochism. Well, fetishism, no, because he's not using objects in order to get aroused. B, exhibitionism, no, although he may be in a public place, such as a crowded bus, he doesn't really want to be seen. C, frotteurism, yes, this is the right answer. Remember that it's sexual arousal by frothing against unsuspecting people, frothing genitals, or I'm sorry, rubbing the genitals. V, voyeurism, no, this is about seeing other people having sex. This is not the case. And E, sexual masochism, no, this is about receiving pain. And, you know, when he's rubbing against women in crowded buses, he's not receiving pain over there.